Thank you, everyone.
All right, good morning. Good morning. For those on the Zoom, good morning. For those that are here, good morning. Welcome. I got in yesterday afternoon, enjoyed a little sunshine. Up in Seattle, we don't get a lot of sunshine. So if I have an opportunity to get a little bit extra, it's wonderful. We actually define a sunny day differently than Seattle. If we can see one little spot of blue in the cloud, breaking through the clouds, that's a sunny day for us. So it's kind of very bright today. I was like, whoa, this is way brighter than we ever get in the winter. But so introduction of myself. I have been in pain management for pretty much my entire career. I started kind of in an oncology realm, but my goal was always to get into pain management. Back in the day, oncologists used to do all the pain management for their patients. They were well versed and expert in that. Now they've switched all over to all their monoclonals and all their fancy chemo regimens and allow teams like ours, the palliative care team, to manage all that pain. Of course, with chronic pain, nobody wants to deal with that anymore. It's kind of like hands off, set aside. So I'm involved in some of that consultation, as well as the kind of the hospice end of life arena, which is a very complex arena. It's something that we strive to do the best possible care and pain management. Some patients were able to be very successful, but sometimes that fear overtakes patients and becomes very difficult. My background is very comprehensive in terms of pain management. I'm a pharmacist by background, so I don't just focus on drugs. So if you're a physician, a nurse practitioner, a nurse, it's not going to be just about a bunch of half-lives and a bunch of stuff like that. I like to think about it from a broader perspective. What are the societal issues? What are the things that can give us kind of a template, if you will, for applying pharmacology appropriately when we need to apply it? And so that's my goal today. And as Charlene mentioned, anytime you got a question, fire away. I want those questions. I want you to interact. There's things that pop up. If you're on the Zoom, you prefer not to ask it over vocally, but you want to type it in. Charlene will be monitoring that. And then as we get close to a break, or even if she sees some burning questions, she'll interrupt me, time out, and we'll answer those questions also. So we want you to feel comfortable enough to do questions, because I think that's the best way we all learn. If you've got that question, I guarantee a few other people also have that question. They're just not going to be willing to ask it. So let's go ahead and begin here. As this world of pain is a complex, changing world sometimes. I've been involved so many years. I've seen the ups, the downs, the fears, the overabundance of prescribing. I've seen the kind of everyone's an addict to nobody gets addicted mentality. I've seen everyone needs a drug to nobody should get a drug. I've seen it's all about drugs. It's all about not drugs. All those different mentalities have gone through the cycle. And I'm not sure we've reached the end point of what the right cycle is. But I do know as a pharmacist, as a pharmacologist, that when we do apply medicines, I want to make sure it's safe, it's beneficial, and that there's a roadmap, if you will, to success. Because sometimes, nobody has a roadmap. They just throw out and say, let's just put them on some oxycodone. Let's just go put them on some morphine. And kind of like, where's the roadmap? Where are we going with this? We do it with other medicines. We have roadmaps for success. And I want to think about it that way. So when you think about these different things about pain management, that's kind of the structure I'm going into. I don't come here with a kind of, if you will, a background bias that says I'm definitely pro-opioid or I'm definitely anti-opioid. It's neither. It's applying things in the right way. It's applying them in a way that benefits the patient. It's applying them, if we're going to use them, in a way that legally makes sense, but also clinically makes sense. And I think when we do it that way, we kind of take that pejorative out of it a little bit, and we don't come at it with such a model where the patient feels guilty, the provider feels guilty, the pharmacist is angry, everyone's kind of fighting each other. This is a team approach. So whether you're a pharmacist, a physician, a nurse practitioner, a physical therapist, a nurse, we're all in this together for appropriate pain management. Now let's see if we got our clicker working. Perfect. Now this is my picture of Seattle that we get a lot of rain, of course. Volume isn't that much, it's just number of days. We are not the most, they have a miserable index. They determined for those that have more cloudy days and relative to sunny days, they call it the misery index. And actually Seattle is not number one. Seattle, I think, is number 3 or 4. I saw one year Pittsburgh was number 1. Portland, Oregon was #1 one year, but Seattle typically hangs out about number 3 or 4 in that arena. But I guess we make up for it by some of the pretty things. Here's a picture of a salmon crossing the road after a big rainstorm. And people might say, why did the salmon cross the road? Well, there's a specific reason. That salmon is going to die. It is going to lay its eggs where it was born. So in other words, if it's still alive at this point, sea lions haven't eaten it, we've not eaten it, this fish will come back to its point of birth, struggle to get there. Obviously, look at this. I mean, it's barely enough water to get its belly wet, and we'll get across to that little area, that little stream, that little side creek, whatever, lay its final batch of eggs, and then die. And so it's a life cycle. So we've always looked at this in Seattle as kind of a measure, if you will, of a good environment if we see a good salmon run. And so here we literally have salmon crossing. We have little signs up there, salmon crossings and so on. So I love it because it reminds me of kind of the nature aspect. And that's why I love Seattle, even though it's cloudy most of the time. I get used to it. So when I need a break, I go to Hawaii. You know, hey, we have ways around it. So if you look at a lot of the headlines over the years, there's this epidemic mentality. And I do believe that we've had some problems with opioid prescribing. But it seems like we've switched gears, and a lot of the deaths associated with quote unquote opioids are the synthetics, the things that we're seeing imported across the border, fentanyl powders and things like that. That seems to be the majority of the effect, not so much the prescriptions, but still we want to keep an eye on prescription opioids. We do not want to cause problems. We don't want it to create more problems. And so I think that's an element of our concern, but we don't want that to overshadow the benefit of an opioid. When an opioid has a role, we don't want to miss that benefit for patients when there's clearly an opportunity for success. You know, statistics say we use a lot of opioids relative to the rest of the world. I find this fascinating. You know, we use 80% of the global supply of opioids, and we represent about 5% of the population. On one side, you could say, make a case that says, whoa, we do a really good job of managing pain. Look how many opioids we use. On the other side, you could say, well, we must be really addicting all these patients. We use so many opioids. One of our physicians in our hospice leadership, he started an organization called Hospice Without Borders and goes to Rwanda a couple times a year. When he started this about 15 years ago, it struck him so strangely that there was no access to any opioid in Rwanda, period. What they treated their end-of-life pain with was Tylenol. He said that was horrible to think that these patients with massive tumors and dying in agony. So he worked with the government of Rwanda, the government of the United States, and began to get a license to import powdered morphine himself and bring it in his suitcase, powdered morphine. I kept saying, man, you better have all the paperwork in line. Otherwise, we're going to be waving at you in your jail cell. And so he brought in kilos of morphine and then taught the pharmacists how to make a concentrated morphine solution to be able to administer to the patients there. And he's done this now for over a decade and has really had some huge benefit. Now, we take for granted that we've got morphine. You write for it, pharmacist fills it, patient gets it all in the same day. Back then, no, it was completely different. And so we're recognizing that while we have easy access, many countries do not. And I think it's important for us to, not look at statistics, and taint us so much that, but we have to recognize that, yeah, we're very fortunate. We've got a huge supply, but that huge supply can also create huge problems. We got to watch for that as a potential risk. If you look at the prescription opioid misuse, they're typically not come from people buying them on the streets, but from legally written prescriptions, neighbors, friends, whoever steal them, borrow them, buy them from their friends, so to speak. And statistics go back many years, but it's noticing in about 2012 was really a lot of a highlight where this thing really crescendoed into a nationwide highlight of a lot of the problems. And we had a lot of pharmaceutical companies being looked under scrutiny, wholesalers looked at with scrutiny, and began to realize is that we were writing enough opioids for about half the people to get one every year in the United States. And I think that we look at that and say, yeah, no, I think where the bigger problem wasn't so much in the chronic pain arena in many cases, it was the acute arena. We had post-operative surgery patients that maybe had very little pain getting 100 pills. And they said, that's ridiculous. And I agree, that's ridiculous because those pills, 1 or 2 would get used, maybe 10, and the rest would get left in the home for often teenagers and others to manipulate. So that became a problem. If you look at the number of people overdosing on opioids, a lot of the overdose numbers, though, we got to recognize that doesn't reflect, that is not just prescription opioids. So I don't want to kind of send us off and go, oh, wow, look how many people on prescription opioids are dying. Therefore, as a pharmacist, we better really be careful when we dispense these. We should be careful. But a lot of those statistics relate to people overdosing on fentanyl powders and carfentanyls and these things that are being mixed and cut in the street. But we also know there's a certain percent of patients who abuse opioids. They misuse them, they manipulate them, they snort them, they shoot them up, they do all sorts of crazy things with them that they should not do. And so there's a certain percentage that we have to recognize that happens with. But if you look at the number of overdose deaths, and we look at the increase, and we look at, it talks about 68% of all overdose deaths are attributed to synthetics. Those are the fentanyl powders, the carfentanyls, and so on. And so that's really an issue that's really recognizing they represent about 20% of all overdose deaths is just the fentanyl analogs. That's really become a heightened area of concern. And probably in your community, your cities, you probably see a lot of homelessness, but you also see associated sometimes with homelessness, a lot of drug misuse. And a lot of it has to do with this fentanyl, carfentanyl, of course, methamphetamine, and so forth. And this, of course, another issue, the percent of hospital births where neonatal opioid withdrawal syndrome occurs. And that certainly can be problematic at birth. The baby could die very quickly if that's not recognized and dealt with very early on. Now, we've had some improvements. We've noticed that since 2012, it's declined the number of prescriptions. I think this is kind of buttoning things up a little bit. If you look at the data from the CDC, it represents a decline in overdose deaths, which was the first time since 1990. If you look at the number of prescriptions, which is the left side, and follow that graph, you'll see the number of prescriptions is declining. And overdoses, even in spite of their escalating, there was some leveling off, if you will. But again, I think a lot of the these aren't prescription opioid deaths, this is opioid overdose deaths in general. So we're almost mixing these statistics a little bit, we got to be careful with. So what's changed? Well, I think there's been an increased awareness, absolutely. We are seeing more and more providers are saying we need to be careful. We need to be judicious when we write for opioids, or we combine them with a benzo, or what other drugs could there be problems with if we combine with an opioid? What are some interactions we need to be aware of? And how do we use things like transdermal fentanyl patches, or should we be prescribing a fentanyl, transmucosal sublingual type of sprays and lollipops and pills and patches in the mouth? Should we be prescribing those a little bit less so, or a little bit more monitoring and following that? Yeah, and I think that's where a lot of people have said we got to change some things. I think there's been some good education regarding the risks and benefits. We always got to be careful when we see education. I don't want to be one-sided. I try to bring my education to say, here's benefits, here's risk. For some people, that benefit exceeds far the risk. And for some people, the risk far exceeds the benefit. And so we got to be thinking about that. It's not just about that, morphine bad, oxycodone bad. For some people it is bad, but for many people it can be really good. It can be a good intervention. So I want to always be thinking about benefit risks so we can make good decisions for our patients, so we can follow through with those decisions and appropriate monitoring, watching for those people most at risk. There's a lot of good tools out there that can help identify who's at greatest risk for misusing the prescription opioids. Very important for us to keep that in mind. And then education on non-pharmacological and non-opioid alternatives. That's been good, because I think it helps us think outside the box, saying, hey, why do we always just default to an opioid? I got many patients that they get on high doses of opioids and that's all they're on. And we consult them, we're like, what was the thinking here? Why did we only use an opioid? Why was there not another strategy in place, an adjunctive drug and non-pharmacological options and other things that could be beneficial? And when that's missed, that's sad, because it's putting the patient at risk also. There's great evidence I'll talk about today about patients that get on opioid-only strategies, that it's not about an addiction risk. Yeah, that's there, but it's also about increasing their pain, hyperalgesia, and causing reactions that if we're only using an opioid and all we're doing is escalating that dose over time, we're creating patients that have more pain than if they would not have gone that route. Now, the patient doesn't understand that, because all they know is they hurt But every time they get an opioid for a period of time, they hurt less. They feel like they do. So it must be the right thing to do. But we're learning that we got to be careful about how we introduce medicines and what that medicine introduction can mean long-term in certain patients. We have a lot of patients that this is their thought pattern. They don't want to do the work, if you will. No. Yeah, absolutely. It's with any med, really. Can't I just keep smoking and use my inhaler? Can't I just eat whatever I want, take my diabetic meds? Can't I just take my pain pills and stop doing all this stupid physical therapy? That's these mindsets. We have to be careful that with acute pain, chronic pain, end-of-life pain, yeah, there's a little bit of things the patients have to do also. Now, obviously, we got to tailor that to who the patient is, where they're at in life, what their age is, and everything else. But I'll tell you, physical therapy is a huge component of chronic pain management that a lot of people miss out on. But even acute pain, after total knees and total hips and so forth, people are not doing their part. They're going to often fall into that chronic long-term problem. And once we create some of those changes in the central nervous system of how pain is being responded to or not being responded to, or how we're taking an excessive amount of medicines, we walk down this road that's sometimes irreversible. So be careful on thinking about, where's the roadmap? What are we going to do? What are we going to get for what we do? And how do we join forces with other non-opioid strategies? Now, all these guidelines we've had over the years say something really interesting. They always say the guideline is not intended for patients who are in active cancer treatment, palliative care, end of life. And they're not. But it's interesting is that sometimes the guidelines are looked at, and remember, guidelines are not law. Guidelines are recommendation, but sometimes these guidelines come out, and as good as they are, sometimes they're misapplied. They blanket them to cover all patients. So palliative care patients get hassled. Cancer patients get denied medicines. Physicians say, I can't write for any extra medicine because law prevents me, and things like that. Those are not good things. So the guidelines are intended for chronic pain, the ones I'm going to talk about today. They're not intended for the hospice patient. They're not intended for the palliative patient. But a lot of times people forget that. And they have to be reminded of that this is a palliative care patient. It's a hospice patient. These guidelines are not intended for that. But even if they were, the guidelines have a lot of leeway that people forget about. People hang on to things that sometimes were not meant to be hung on to. And so even the Centers for Medicare and Medicaid Services, they make the same statement that patients in long-term care and hospice care, receiving palliative care, these guidelines are not meant for them. So keep that in mind as we hear the rumors of different things that must be, can only give, morphine equivalents of 50 milligrams per day. Well, where did that come from? Well, that doesn't apply to palliative care patients, doesn't apply to cancer patients. It can apply to chronic pain patients, but it's not meant to be an ultimate hard stop. It's meant to be a soft stop of reevaluation. For some patients, it becomes a hard stop after evaluation. But we got to be careful there that we don't take these guidelines, apply them in a way. I mean, I've heard major chains like Walmart. They say, we're not going to dispense any morphine that's more than 50 morphine equivalents per day. And then pretty much it came, we're not going to dispense any morphine whatsoever or opioids. And again, what's that do to the care of patients? We have great pain practices, physicians, and we have great teamwork that goes on in the treatment of chronic pain, but sometimes that's all negated by a lot of things that are misread into some of these guidelines. We got to be careful. So this survey asked cancer patients, pain patients. It was done about 4, 5, 6, 7 years ago now. Yeah, 6 years ago. And it focused on people who have had or will be taking or currently taking opioids. It mainly focused on cancer and palliative care patients with some chronic pain patients in there also. And what they did is they just basically did a survey. And the survey said, what goes on when you deal with a pharmacy? What goes on when you deal with your provider, insurance companies? How does this affect your care in terms of pain management? And so about 40% of cancer patients and their survivors could not get an opioid because the pharmacy did not have the drug in stock. Now, we saw a lot of that in the early 2000s when windows of pharmacies, I remember New York, walking down the street in pharmacies, huge signs, bigger than the name of the pharmacy. We do not stock oxycodone. And I get it, but yet even still, they said a third of the patients, even their palliative care cancer patients, they were questioned, why do you need an opioid? A quarter of them said pharmacists would not even fill the medicine, even if it was in stock. Now that's sad. So that's an indictment on my profession, the pharmacist. But then you start looking at, it says the insurer. A third of the respondents said their insurer would not cover the med. And that's rising. That was a number that had gone up from 2016. Other barriers, some of these are perceived as barriers, but we have to consider maybe there's some safety there, but a quarter of the patients said limited to just one pharmacy, limited number of pills. And again, majority of these are not chronic pain patients. Half the cancer patients and survivors said their physician told them that pain treatment options were limited by laws, guidelines, or insurance companies. No, they're not. They're not. That's a false statement. It's a misunderstanding. A third of the patients said their physician refused to give them an opioid prescription. Cancer and end of life, and the physician's refusing to give an opioid? Wow, that really is, to me, is bad care. It doesn't mean they always need an opioid, but to say they refuse, period, that's saying fear is dominating, not clinical experience practice. And a quarter of the patients said the pharmacist only dispensed part of the prescription and advised them to come back again if they needed more. I know how that would work. So we have to be careful on looking at these guidelines and how they can affect the unintended consequence. What can they do? Why do we want to treat pain? Well, I think there's many reasons. I mean, I can think of many, but certainly I went into pharmacy with a notion, and most people in the medical world that says, I want to be compassionate, I want to care, I want to do good, I want to help people. And certainly pain is an area that destroys lives, and it can lead to a lot of dysfunctionality. And we've recognized over the years, if we do good pain management doesn't mean just throwing drugs at it. It can be a variety of strategies. But if we do good pain management, we wind up that we improve healing, we improve functionality. You know, I've looked at over the years the notion of when total knee surgeries, because I had a total knee about 4 years ago. And mine was secondary not to osteo, but due to an accident I'd had, and had to have this total knee surgery. And I looked at the statistics. Statistics bore out that, man, people really take a lot of opioids when they have total knees. And I was like, that doesn't make, I guess for a little bit you might need it. So I talked to my provider. I said, tell me what you do in the immediate week after surgery, and tell me how people get the greatest success to have full range of motion. They all have a limp. They can go back to normal function. And he said, the key, and this was great. I love this because he was clearly on top of the literature. He said, the key is keep the pain as low as possible for that first week when it's going to be its highest level, so you can get in a habit, build up some basic exercises and work with physical therapy. I says, you mean you go to physical therapy in the first week? He said, you go there on the first day. I said, really? I said, well, I'm ready. I'm signing up. But I says, what else can we do? And he says, this is the ticket. He says, I'm going to put a bulb device connected to one of the nerves in your knee with bupivacaine. It's going to release slowly over 3 days. After 3 days, you're going to pull it out. I waited till after the Rose Bowl and I pulled it out. And he says, for the first 3 days, you'll think I'm a genius. After that, don't call me. In other words, what he's saying is, yeah, we'll hurt a little bit after those 3 days. But what he did is he says, those first 3 days, we're going to blunt it enough so that you can recover, do some of your initial exercises to start that process. But then he said, the key isn't opioids. He says, the key is non-pharmacological, cold. He says, ice is amazing. And so I looked and did the research and bought one of those. It's a portable ice chest with a device that circulates water through a tube that then wraps around a kind of a cover over your knee, and it circulates the cold water. Man, that was better than any opioid, trust me. That worked. Opioids just kind of made me like, and whereas the coldness made the difference. And so I began to realize that, yeah, I was able to function. I mean, they were amazed in physical therapy. They said, I clearly was a person not only motivated, but was doing what they asked me to do. Because within a week, I was at close to straight out in terms of this motion, and I was close to being able to almost have full flexion and extension. And they said, that's amazing. And I was able to be pretty much back to normal within a month, where I had no limp, no nothing, but it was because I was not just relying on opioids. And I'll show you this study in a little while that talks about the risks of opioids in total knees and other joint surgeries that we got to be careful about. that we don't want to just rely on it and say, I've got pain, I hurt, I need. We sometimes have to work through it in other ways. But I just know that if we get good pain management, not just about opioids, but we can clearly improve patients' care and functioning. I also believe is a moral imperative. I see this in hospice, where patients just, they give up. Why do they give up? They give up because they're suffering. And they're suffering sometimes because we're not applying pharmacological principles appropriately for them. And hence their pain levels are constantly 8 to 9 to 10 out of 10 all around the clock. And patient says, this isn't worth it. I'd just as soon die. And I've discovered that we get good pain management. People are not interested in that. They're interested in having conversations with their loved ones, with their grandkids, going on a walk. That's what they're interested in. When pain is so horrible, they can't. So we got to be focused on, say, how do we manage this pain appropriately across the board, recognizing there's no one tool that does it all. So if we don't manage pain well, we affect physical functioning, psychological issues, depression, anxiety, anger, self-esteem. We also have social consequences. You'll see patients with chronic pain, but even end of life, it affects the whole family. It affects everybody. It really is a concern. I see this tremendous family dynamics that are destroyed, affects intimacy, and people get isolated. And then, of course, healthcare costs go up, disability, lost work days, a lot of things happen. But we also have to recognize there's a lot of risk if we just use opioids. If opioids are a tool, we just keep pounding on opioids, some patients get on benzos, and they're discovering benzos and opioids are a bad combo because we increase the risk of overdose and deaths, especially in those opioid naive. You think about when patients are started, there's kind of your time periods where there's the greatest risk. If you're opioid naive and you're getting an opioid for the first time, you are at greater risk than you'll be at other points of that opioid therapy. That first initial dose or two, because your body's not used to it, you may have a greater risk for respiratory depression because that threshold may be lower for you than what you needed to take for pain, depending on the type of pain. So we always got to be careful there. We think about when patients are first starting an opioid, that's an area of risk. That's why we now have programs around the country to get patients with nasal Narcan in the home, which I think has been an assist to probably save many lives over the years. But another time period that is risky is when we add a benzo into that opioid. They've not been on benzos. That includes the Z drugs, includes temazepam, clonazepam. It includes all these drugs that sometimes we don't think about, not just your Ativan, your lorazepams, and your Xanaxes, your so forth. It is inclusive of all opioids. That's a much increased risk. And the statistics have borne out that a lot of people believe, looking at statistics, that benzos probably account for about 30% of the combination effect with an opioid. So it's not just the opioid alone. In fact, when you analyze people that have died on opioids, you do a post-mortem toxicology, you find out it's not just the opioid, it's often multiple drugs, including benzos, including other CNS depressants and so forth. There's been a lot of static within that. A lot of people wondered, some studies, I think I include that in this presentation about gabapentin. And does gabapentin increase the risk of overdose of opioids? I do not believe it does, but some studies have kind of teased that out. And I'm not sure there's hard enough core evidence to prove that, but it's interesting at least to see some of these studies. But definitely benzos have been involved. And so I always suggest when a pharmacist gets a prescription for a patient, if it's an opioid and a benzo together, there better be many questions asked. Is this the first time you're taking these meds? How long have you been on them? Has the dose changed? Because that's another risk factor, is when the dose increases. That's why we always are cautious. Where the rules with the FDA have talked about you don't start people on long-acting extended-release opioids. They've been on for at least a week or two, a short-acting at a certain dose level before we want to advance them to that next level. Yeah. Okay, so you're talking about, so still in combination with an opioid. So what are the statistics that bear out for a person who is not a drug addict, but is a person, they're going to be higher in a person who's not an addict? Because the addict has got tolerance already built into their system. We don't. Now, if you're talking about multiple drugs, yeah, now we're starting to increase the risk to another area. So if we're talking just opioid and benzo, Your highest risk patient is the opioid naive, benzo naive person being put on both. And I've seen that in prescriptions for that. And it's downright scary because I don't think we should do both of them together at all. And I get it. You know, we use a lot of lorazepam in end-of-life care. People say, well, why is it so safe there? Because they build up tolerance. They've been on opioid for not just sometimes a few weeks, but sometimes many months and sometimes even many years. So they build up a tolerance. Throwing in the benzo increases the risk, but it doesn't throw that risk so far much higher we could not do that. But it is still, at least our antenna should be up, looking at a lower dose. Of course, age plays into it. You know, I get real concerns when we recommend to put morphine on a 90-year-old. People say, whoa, you give morphine to 90-year-olds? I say, yes, and even 100-year-olds sometimes. But we give a lower dose. We don't start at this high level. So again, thinking about your risk factors is age is certainly. What about their underlying other disease states? There's been connections to looking at overdoses and people that have certain chronic conditions where they're on multiple other meds that obviously have interactions, but also just the general condition of who they are. So we look at renal function. We look at a lot of these factors, but absolutely a factor is naivety. You are opioid naive, benzo naive, and you start on both those drugs together, your risk is way higher than anybody else at that point. So always be careful in those areas. The black box warning, the FDA had it very much warning that says, you know, got to be careful, the seriousness of opioids and benzos together. And then we look at the substance abuse treatment admissions, co-abuse of benzos and narcotic pain relievers increased a lot in the decade prior. So if we look at that, we're recognizing is that, yeah, there are risks that we always got to be aware of. The opioid and benzos, it's not just benzos, but opioids with benzos or other CNS depressants, alcohol. That's another biggie that we got to be careful about. For those not aware of, you know, the reasons why we worry about alcohol, there's really twofold reasons with alcohol and opioids. Number one is obviously the synergism of leading to advanced CNS depression and respiratory depression. But we also recognize that alcohol, from numerous studies from previous decades, really, it's now been out, that certain long-acting opioid delivery systems dissolve more rapidly when alcohol is in the stomach at the same time. And the higher the concentration of alcohol, the greater that risk will be. So beer, wine, and vodka is your highest risk. The highest risk time period, though, is what's important also. It's within that 2-hour time period of drinking alcohol and opioids that you're going to have that greatest risk of mixing within the stomach contents and create a rapid dissolution of that opioid. So the opioid long-acting, instead of delivering over 8 or 12 or 24 hours, it delivers over 1 or 2 hours. Obviously, that's a problem because now we've basically heightened the blood level tremendously. So this is why we always tell our patients no alcohol. The only exceptions we sometimes allow is we get a hospice patient. They say, I like a glass of wine with dinner. And we say, okay, but no opioid within 2-hour window of that alcohol. So in other words, 2 hours before or 2 hours after, and that includes short actings. So we're very cautious and we limit it to one. They're staying in the home. I think there's an exception we can live with, and they can live with, literally. But if we're having patients who sometimes, you know how it is, there's always exaggeration of, they down exaggerate how much alcohol. Well, I only have 1 beer a day. Yeah, 1 6-pack you probably mean, or, you know, I only have 1 drink a day. Sometimes that means it's a pretty big bottle and they're drinking it all at once or something. So we have to recognize that we don't want to give carte blanche approval because there's certain risk that we got to be careful about with alcohol that can be dramatically escalated. So the FDA calls that out. And we have to recognize that, yeah, we can use them concomitantly, but making sure that we are watching our doses, watching that patient, having a level of monitoring. The thing about hospice that people always say, well, why can you do all this stuff in hospice? Well, because hospice has in-home care by nurses. They have constant contact with nursing care, with physicians, and so forth. A lot of other patient groups do not have that level of intense monitoring. So we can often do things in hospice, recognizing there's a risk, but there's also a huge benefit, but we're mitigating the risk a lot. But the benefit is so high in some of these patients that we will do the things together with very little risky outcomes, as long as we keep our eye on everything. But the risk obviously is the synergism, but then also the benzo, some of the 3A4 interactions, things like alprazolam. And that can be a risky issue that makes the opioid more toxic. The opioid makes the benzo more toxic, and you have this synergistic effect of blood levels. We always got to be careful there. The good news is lorazepam does not go through this 3A4 system, so you don't have that direct interaction, but you certainly have other risk. And just as a side note, this is something that I get addressed a lot of times in our pain practice. A lot of people have sleep issues when they're coming in with pain. And it can be end of life, it can be a chronic pain patient. And what's so, they want to know, what Z drugs and so forth. And from the evidence I can see is that while Z drugs appear to be safer than benzos in general, they still seem to rob people of that level, that deep level of sleep that over time, they take these for too long, it does create long-term sleep deprivation syndromes. It's a risk. It doesn't occur in all patients, but it certainly can. But benzos definitely do that. We've had patients come into our chronic pain clinic who've been on benzos for sleep for a long, long time, and they're not sleeping at all. And just because you're out doesn't mean you're asleep. So we also then speak against things like diphenhydramine. I don't know how many patients you ever see take the Tylenol PM. They swear by it. But Benadryl is really not a good sleep drug. It's a good drug to knock you out. A histaminic effect can cause that, but it also has a lot of anticholinergic effects, and that can obviously have risk as we get older, urinary retention, confusion, agitation, risk of falls, and so forth. So if we're going to stick to drugs, I do kind of like some of the data we've seen with the Silanor, the doxepin low dose, 3 and 6 milligrams. I'm not convinced that those doses work for every patient, but doxepin, anything less than 20 milligrams has very little anticholinergic. It's pretty much all histaminic. If you look at the studies with doxepin, it's probably a really good anti-itch drug relative to a lot of antihistamines. But in terms of sleep itself, I would prefer not to use benzos. I prefer to use simpler things. Melatonin's an option, although I don't like the Costco 10 milligram doses. I think 10 is too much. That's crazy in my book. But I think 3 milligrams seems to be a reasonable dose to, 1 to 3 milligrams. But this 10 milligram stuff is like, wow. But I prefer the things like melatonin, doxepin. Sometimes we use mirtazapam. Looking for things that are not going to rob people of sleep, but they're certainly not going to be the same knockout effect. And we know that sleep is more complex than just, I can't sleep. It's usually a lot of fear, stress, worry, a lot of stuff, bad sleep habits, watching TV till 3 in the morning and thinking you're going to sleep. Ain't going to happen. You're kind of like, work on your computer. They say leave a 1 to 2 hour time period. Probably 2 is better before you go to sleep. Put away all the blue light stuff and just kind of set yourself at a pace. I learned a recent fact I thought was really good. A guy wrote a sleep book, forget his name now. And he talked about how body temperature plays into this. And he says it's really important for people struggling with sleep to cool your body temperature down. So in other words, don't get all warm before you go to bed, get nice and cool, then get under your covers when you're cool, and you'll find out you'll sleep a lot better. I thought that's a really good point. So if you look at acute pain, why do we all manage pain? Well, we know that acute pain, we can improve their ability to do physical therapy. We know we can improve their ability to just recover quicker, but also we know there's a certain subset of patients that go from acute pain into chronic pain syndromes. And we can't always predict ahead of time who those will be, but we know there's a certain connection. And so a lot of times the connection is unmanaged acute pain down the road leads to some problems. Again, managing it doesn't just mean we throw opioids at it. There's a lot of other strategies we need to be focused on for these patients. We know pain is complicated. There's no pain meter. We don't always know the reasons they've got pain. It's influence. This is an area that we spend a lot of time on. And I think it's important for us to recognize the influence of the patient's past history with pain and with other conditions, because that will influence their future ability, how they respond to pain. Studies have looked at people who have used opioids long-term in the past, probably will have a greater difficulty with pain management in the future with acute pain surgeries and so forth. Because what we've done is we've changed the nervous system, we've heightened its awareness, we've turned it on a little bit more. And that's more difficult now to turn that off now that they're having an acute incidence of pain layered on top. But we also know psychiatric comorbidities, stressors, fear. I find at end of life, fear is a huge area for not being able to manage pain. And once we get fear under control, then we often get pain under control. That's why we use some of the adjunctive drugs. Sometimes for patients who are, and I've not applied this so much to chronic pain patients, but I don't, there's a reason why not. But sometimes in the end of life, the hospice patient has a lot of fear, ruminations, always thinking about pain, worrying about what's going to happen. We use a little bit of olanzapine, Zyprexa, and that seems to cut, if you will, that mind ruminations, that cuts out sometimes a lot of the fear. We find a lot of patients been able to, who have uncontrolled pain secondary, not just to physical effects, but to psychological fear. That's what's driving it. So we always got to drill down. What is the reason this pain is at its level? Why is it happening? Why is this pain out of control now? And if we think it's fear-based, we'll sometimes use this, a low dose of olanzapine, 2.5, 5 milligrams, maybe as high as 10, but that'd be the max. So it's not a schizophrenic type dose, it is a lower dose, but it's good anxiolytic. And we find that highly beneficial for those patients with pains out of control. So those stressors. And sometimes it's difficult to distinguish what's appropriate pain-seeking behaviors, what are addictive behaviors. Sometimes how do we measure this patient's improvement? I've never been a person who loves the pain scores. You know, we focused on pain scores a lot. You know, what's your score? Everywhere you go, what's your score? And pain scores are okay, I think, in certain populations, but they can obviously be manipulated. And manipulation of the pain scores, you know, I need to tell the right score so I get the right med, so I get more of the right med. So I'll tell the score that I know that will get me there. And so those pain scores can be problematic in some of those arenas. We like to focus on is the function score. How is their function improved? One of the tools we use a lot of times in our chronic pain patients is we ask them, say, if your pain was reduced by 50%, so we use the number 50. So a lot of the studies are powered to 30 or 50% reduction in pain. So we say, if it could reduce by 50%, what things would you like to be able to do that you can't do right now? So we have them drill down in their own life, what matters to them. For some, I want to go on a bike ride with my kids. For some of us, I want to go on that cruise with my spouse. For some, it might be I want to be able to go out fishing. Whatever those things are, we try to drill down, get them to identify 1 to 3 things. Now, if we're going to implement a drug therapy, we have something we can measure it against. Are they able to do those things that they said they would like to be able to do now that they're on a medicine? And if they can't, it makes me wonder, is the medicine really improving their life? We don't want medicine so you just feel good. We want it so you function well. And so we have to think about in our patients, what are they not able to do now? How has pain destroyed their life? We've had patients tell us, oh, I can't do anything. Now, obviously, that's an over-exaggeration. I mean, there are some patients who clearly can do very little, but we say, who gets your mail? Well, they do. Well, let's get your mail twice a day. Let's start slow. In other words, if you walk out to the mailbox to get it once, then do that a second time. And then pretty soon they're doing it 3 times and 4 times. Pretty soon they're walking around the block. Is this occurring over a period of a week? No. It sometimes takes many months to reverse these behaviors of people that have gotten so inwardly bound by their pain that they're doing very little, doing not much of anything. We try to work on getting their diet changed, try to work on where's their sleep at. But we try to have them identify what are they able to do, and then we try to extend that a little bit. Are we able to achieve those goals? So we look at it not just as a pain score, but is the ability to manage that pain influencing their life. A study done by Charles Cleland, he was a past president of the American Pain Society many years ago, and he looked at how to correlating pain score to how it affects people's lives. And he put it in 3 groups. Pain score of 0 to 3 pretty much had no effect on sleep, pretty much had no effect on functionality, on activities of daily living, and so forth. Said maybe even up to 4. Pain scores of 5 and 6 had a moderate level of influence. Sometimes affected sleep a little bit, sometimes affected functionality, affected ability to care for self, and so on. But he began to show pain scores of 7 and above clearly influenced and affected this patient's life. They couldn't sleep, they couldn't sometimes even have conversations with loved ones. It was so bad. He said, so the goal isn't to get pain to 0. He said, if your aim is to get pain to 0, you're going to have patients with chicken soup dribbling down their chin, barely able to open their eyes because you've over-medicated them. But if we can get pain scores less than 4 or less, he says, we've been hugely successful. That's what I hate about pain scores. Everyone wants a 0. If you don't get a 0, man, you failed. You're not at a 0, you need more med. No, I would say if we get it less, 4 or less, we should be saying, we're doing a good job. Because we ask the patient, if we got your pain score cut in half, would it be meaningful? Virtually every patient says yes. That means go from an 8 to a 4, a 10 to a 5. Now, why is it not meaningful? Why has this patient now say, I need to get it lower? Because of expectations, because everyone wants a 0. Well, we can't reverse life that way in many cases, but we can get it low enough. I think we need to aim for reasonable goals and not try to accomplish things that really can't be accomplished without over-medicating the patient. So if you look at what's our goal, is a decrease in pain from 9 to a 7? Is that meaningful? How about limited ambulation? What about how we achieve certain goals? In end of life, we aim for a lot of patients. What are your expectations? And we also say, what would you like to do? Many of them have goals. They'd like to go on that final cruise. They like to garden again. They like to go for a walk on the beach. They would like to see their grandkids and so on. So we try to aim for those goals that are reasonable, because that alone helps pain get better. When people achieve things, we are achieving. That's how we're made as humans. When we achieve, we feel better, typically. But vast majority, we do something, we feel better. That feeling better, all of a sudden, guess what? The pain gets better. There's no medicine involved there. It's internal dopamine reward system being activated by us doing things, accomplishing things, being able to do some things we didn't think we could. Gets us kind of a little excited. It says, yeah, this is good stuff. Look what I'm able to do. Now, sometimes we got to push a little bit to get the patient back into that mindset because they've become so disassociated. The reality is everyone's pain stinks, and everyone's is, the worst pain imaginable for them. And I get it. We also got to keep our perspective of where we're going. What's our roadmap? How are we going to get to that roadmap? What are we going to use to achieve that goal? And when we achieve it, what are we getting besides just a pain score reduction? That's going to help us. It is about function also, not just about, I want to be comfortable, but how do we get a patient mindset change to say, what can we do? We have a lot of patients in a chronic pain arena. We get them involved in volunteer work, because again, that reactivates the dopamine reward system. I find rarely do people feel bad about helping people out. People feel good about themselves. They feel good about doing something for somebody. There's a certain thing that stimulates us to be able to say, hey, that's good. And that means when they feel better, they're not going to be so focused on their pain, and they're actually going to use less medicine. We have a lot of patients that their one tool is that medicine, and they're literally, watching the clock, and that's all they're focused on. That's a patient we got to change that mindset and move it. Otherwise, all the medicine in the world is not going to help them. So in the state of Washington, years ago, they started with this notion of the 2-element assessment. One is what's your pain score, but the other is how does that pain interfere with your activities of daily living? The state of Washington said to have a meaningful change, it better be at least a 2-point reduction in both of those. So the pain score's got to reduce by 2, and how the pain's interfering with their activities of daily living need to be reduced by 2. Is that the right reduction? No, but I think it's a good start. I would love to see 50% on both those. That would be wonderful. But don't expect it to be, my pain is 0, and I'm doing everything I used to do when I was 20. Don't I wish? Overprescribing opioids. Why? Well, I think sometimes it's been this lack of training for years. So I think we're getting better training now. The medication mania, not just opioids, but every medicine. We got an answer with meds. It's always a ticket. Families overly focused on opioids. Sometimes providers have confrontation phobia. Yeah. You got to sometimes say, I've had providers tell me before, well, I don't know how we're going to get this patient under control. Who's writing? Yeah. Guess what? You have more control than you realize. But you have to confront the issue. You've got to be straightforward. Why do we not want to write for more opioid? Well, there's many reasons, not just that I think you're an addict, but it may mean that we need to look at your medication and say, what could we be doing that's causing harm, making your pain worse, including the opioid? That doesn't make sense to patients, but we need to explain to them how the body reacts. It's called this hyperalgesic component, which we'll talk about, because we don't understand how that works, we can't explain it to people. But when we explain it in layman's term, how opioids can actually make the pain elevate, they can begin to go, you're right. I've kind of gone from 3 Vicodins a day to 12 Vicodins over the last 3 years. But yet, guess what? Their condition has not changed. It's not like an end-of-life patient where their metastatic lesions have now spread from, from their bone to their liver to their, their brain to the lungs, on and on and on. We have to recognize is that patients sometimes don't understand these phenomena until they're stopped and said, let's just go back and think about what's happened. Have them reflect, because that will alone help them to educate themselves. Not every patient. We know some patients need to be clearly kind of steered. And sometimes our steering is not easy to do, but it is important that we confront and we steer with the goal of not eliminating every med we're prescribing, but the goal of being, let's retool this to say what makes the most sense. Sometimes we enable and we get kind of codependent. Wow, you're really suffering. Whoa, that must be really bad. And all of a sudden we now start a model of focusing on how we would feel if we had the same condition. Therefore, this is what I would want per se. And we got to be careful on that. That's not the mindset we need to have. It's where's the science leading to us with the use of medicines? And does that science lead us in a way that makes the most sense for this patient? Yeah. Yes. Oh, yes. Right. So the question is patients that begin to develop hyperalgesia, how do we deal with them? I'll talk about that in a little while, but a kind of a scenes of coming attraction is all of those things, as well as even some adjunctive things to downregulate. We've got to look for ways to downregulate that nervous system. And that's been a lot of research looking at how we can best do that. Yeah, and so sometimes it's changing the medicine they're on, the opioid they're on. Sometimes there are certain opioids we know that cause a little bit more of a dopamine surge, like oxycodone. Sometimes we have medicines that we've steered away from that have a great benefit on the nervous system, like methadone, tapentadol. If you've ever used Nucynta, it's a dual mechanism agent also. And so we have to recognize we've got some tools out there we can utilize to minimize this risk of hyperalgesia. Or once it's occurred, we got tools to how to reverse it. We'll talk about that in a little while, but great question. So the question on opioids is, should this be our model? Danger ahead, fasten safety belts, remove dentures. I think safety belts make sense. That means good monitoring. It means writing things that make sense, balancing benefit and safety. But if we look at the remove denture component, that means we're going to be so fearful. We're going to underdose, not dose. We're going to do things inappropriate. We got to be careful there. We got to be careful, not only from the physician standpoint, but from the pharmacist standpoint. How do we counsel patients? We had a pharmacist, and these stories, you can't make this stuff up. These things happen in real life. And there's a palliative care patient, no less, went to the pharmacy to get their newest dose of morphine. They had been on morphine a long time, and their dose had slowly escalated based on their disease state to where they were taking about 600 milligrams a day of oral morphine. That is a large dose. The pharmacist's first words out of their mouth, and this is quoted by the patient's wife, confirmed by the patient, said, "This is a lethal dose we are giving you." Now, is it a true statement it's lethal? Yes, if you and I took it, it'd be lethal. Is it lethal for them? No, they freaked out, of course. What is the doctor doing to me? Yeah, I would, like, whoa, what's going on here? Okay, we got to be so careful how we word things, how we counsel, how we frame it. I think it'd be appropriate to say, this is a large dose. Have you been on morphine before? Is this something, the pharmacist was unaware of that? Ask a few questions. Oh yeah, this was a recent increase by the palliative care physician because the pain was uncontrolled. We'd been taking 150 3 times a day, and the doctor wanted up to 200. Okay, it makes perfect sense. It is a large dose. You might get more constipated. If you got enough things for your bowels, have a conversation like that would make more sense. But all of a sudden, the fear-based mentality is, this is a lethal dose. And we're like, no. So we got to be careful about removing dentures on these things. They can really create problems. So what about illicit use of opioids? Does it occur? Absolutely. We got to keep our antenna up on this. I think there was a much bigger area back in around 2010 that we saw a lot more of a risk, if you will, from the prescription opioids, but now it's again the non, manufactured stuff. It's now the stuff being imported in powdered forms, synthetics, and so on. But absolutely, people still take and co-ingest with benzos, TCAs, cocaine, and so on. Sometimes they deliver it, they crush it up, they snort it up, put it in a slurry, they inject it and so forth, or some crazy new things. We've got this carfentanil approach, which is a tranquilizer for animals, about 100 times more potent than fentanyl. But now we got these crazy things of alpha methylfentanyl and 3-methylfentanyl, up to 2,000 more times potent than fentanyl. Think about that for a moment. That means we're talking a lot more potent than morphine. So just a speck of this could lead to an overdose of you and I. And that's why this stuff is so dangerous, because people on the street don't know what they're getting. There's no label that says you are now about to inject X number of milligrams of fentanyl if you've not had this before, obviously. And so they inject it and they die. That's why sometimes we see clusters. You've probably seen it in your community where there's clusters of overdose deaths. 12 people in one area die in one night. You go, whoa, what happened? Who brought in the synthetic? And that's typically what it is. But this also affects first responders and so on, because they got to be careful now when they touch people who've overdosed, because they can actually get that on themselves. It can be absorbed through their skin. They can overdose. That's happened before. So it's very important for us to, be thinking about all these ramifications of these new powdered things. We also know, though, that patients can overdose by doing things inappropriately, not illegally, but it's inappropriate because they don't understand. So they take the long-acting, they break it, they chew it, they crush it. Those are bad things because that can make that an instant release product instead of a slow release. We give the wrong dose or delivery system in opioid-naive patients. I've had people suggest, could we use a fentanyl patch in this patient? And I'm like, where'd that come from? The lowest size fentanyl patch is worth at least 6 hydrocodone 5s. Is that something we would, is that reasonable for this patient? Or we have patients who are getting in a nursing home, maybe 2 Vicodins a day, and someone says, they're having trouble swallowing, let's put them on a fentanyl patch. And I said, do you mind tripling their dose? What? Yeah, that's what you're doing by putting that fentanyl patch on, you're tripling their dose. So we got to be thinking about which delivery model we're using and so forth. Sometimes wrong conversions. A lot of literature has been looking at how do we appropriately convert, how much hydrocodone is worth how much morphine, and how much oxycodone is worth how much morphine. And there's a little bit of disparity, but we've come to more of a consensus. A lot of the conversion data is not based on science studies. Some of it is, but not as much as I'd like it to be, but it's more on professional opinion. We've kind of honed in over the years and decades of doing this. We kind of know where it's going, what the framework is. Some of the reasons patients also overdose, the patient error. We know that patients misread things because we do it ourselves, or they forget they took a dose, or they'll leave at their bedside at night, both the long-acting and the short-acting. They wake up middle of the night and they take the wrong medicine, which they took the long-acting instead of the short-acting by mistake. They crush things. They're doing things with alcohol, even certain foods we know interact. We know there are patients not tolerant. The conversion, providers making a change in the office and going from a oral to a fentanyl patch. Is that the right conversion for that patient? It never hurts to, as a pharmacist, when you get those prescriptions, to ask the question, what were they on? And the doctor changed to this. Does it make sense? Is it really the appropriate conversion? Because I think every physician would be very happy to talk to you if it's the wrong conversion, especially if it puts a person in a likely overdose. I've had many times physicians say, you have saved my license again. And they're thankful. But again, as pharmacists, we want to come with not the arrogant attitude, but with the humbleness, saying, hey, we noticed something. We just want to double check with you. Did you intend to increase the dose by this level? And that kind of gives an out to at least say, no, we did not plan that. Thank you for catching that. Because I think it's important. We work as a team. We have a very good relationship in our organization, and the pharmacists are part of that team. But I learned so much from the physicians, from the nurses, from the physical therapists, from the psychologists. I just love to soak it up because I don't have all the answers. Drugs aren't the only answer. And so I want to learn from the other part of the group. What are you looking at? Why would you think differently? why do you think this would not be a good decision for this patient, the medicine? That helps me understand the bigger picture, not just looking at it through my eyes. And so patients, though, we have to recognize we're part of this big picture. So we want to be part of that. Inappropriate use of fentanyl products. We'll talk about some of that later on. And then methadone. We'll talk a little bit about methadone, recognizing that methadone, I don't want to avoid methadone. There are some providers around the country. I don't know if anyone knew Mary Lynn McPherson. You ever heard of her? She's from St. John's. She's a big methadone proponent, which she has been really good at educating the world that methadone is okay to use. She's a PharmD, is a educator, speaker, all these things. I know her. And while I think she kind of goes a little overboard on everyone being on methadone, but she does open the eyes to say we should not ignore a very valuable strategy called methadone, which has a dual mechanism approach. It works on the opioid receptor, also works on the NMDA. So we're getting a dual effect. So we shouldn't be afraid of using it, but we should be cautious in how we use it. And I'll give you some tips today about that to make sure if we use methadone that we understand it. So in preventing errors, obviously with patients, I think the education doesn't start and end with the pharmacist. It starts and ends with every visit with every provider. So it should be thought of as anew each time. The patient may come to the pharmacy and say, oh, the doctor already told me about that. I'd like to tell you some more. Because guess what? They may have not heard it all, or they may have heard it erroneously, or they may have tuned it out, or they may have heard something that is not true that they thought they heard. And so it's good to start again, and let's go over it and make sure they get it again. If they've got questions, we certainly can talk about what those disputes might be between what we're saying and what they thought they heard, so we can get through that. But we assume they're going to go home, go on the internet. They get a lot of wrong information. We know written and oral is important because we know people are, when you're talking to them, our mind is racing always. We're always thinking something else, what's the oven's still on? Did I leave it on this morning? Everything's going through the years. And all of a sudden you go home and go, what did they say? But if we got something written down, we can read that again. And then, of course, making sure pharmacists are open to set up special counseling sessions, specifically to go over more in depth around pain meds and drug interactions. Of course, we're reviewing for those also. And then, of course, cannot overemphasize, do not cut, chew, mince, break, blenderize, whatever your long-acting pain pill. No heat source on transdermal fentanyl systems. This was a big, big warning. I think we've lost a little bit of it over the years of recognizing deaths do occur from fentanyl transdermal systems. When people apply heat near or around that patch, it can dramatically escalate the delivery of that fentanyl into the system, which can lead to an overdose. As I mentioned earlier about alcohol, and then of course the OTCs, herbals, and grapefruit juice, making sure that there is a conversation that occurs before they do that on their own. When we talk about mitigating risk, we talked about, earlier I said, the reason we should have some nasal Narcan in the home because it has saved lives. And we know that over the years, we had naloxone, which is the competitive antagonist of the opioid receptor, the opioid receptor, works wonderfully well. We know as an intravenous, it works very well. It's a fairly short half-life, though. It's not like it's super long. So they did some studies on and recognized that they could take the nasal form, the 2 and 4 milligram, and recognize that gives the equivalent dose as though they were getting an injection. You always got to keep in mind that nasal or even injectable Narcan's half-life may be shorter than the half-life of the opioid they've been getting or overdosed on. And so giving a dose, they may rouse, but then go right back into the overdose. So the recommendations around that is that we got to make sure we're ready to repeat that dose. So if you look at the nasal Narcan spray, the one spray, intranasal, it's 4 milligrams of naloxone, and that was basically compared to studies with injectable, shown to be very equivalent in terms of what you get for a blood level. So that's why they came up with that dose. Recognizing that if we have a suspected overdose, obviously family members should be educated on this, but even ourselves, we could be good Samaritans. We might encounter this. Obviously shake their shoulder, shout to them, hey, you okay? Look for signs of an overdose, unresponsive, the breathing shallow, the snoring, the gasping, lips, fingernails blue, and so forth. Then we give it as quickly as possible. Even in doubt, you can use Narcan. But we always recognize that when we give nasal Narcan, this person may go into acute withdrawal. And that has its own ramifications. And so they could vomit. So we're obviously going to lay them, tilt them after we give it to them. But remember, you never prime that device, because if you prime it, you've given it in the wind. No prime. one nostril, one spray, discard. If they need a second one, use the other nostril, unprimed, administer. So it's really important. Just remember, never prime, switch nostrils, do one nostril, one the other if you need to. And so I always love these instructions. It's like the mattress pad. Do not remove this label. Remove device from patient's nose. Of course we would. So then we seek the emergency help. So it's not a substitute. Narcan nasal is not a substitute for emergency help because this person could go right back into overdose, move the person on their side, making sure that we prop them up, watch them closely. If they don't respond in a couple minutes, then we may want to give another dose. So those packets come in 2. Now, obviously, the odds are they may not have that. So we may have to have that as a good Samaritan in our car or something. But if we had to administer, if the family had administer at home. But opioid withdrawal, though, can be an aggressive, or a lot of behaviors can happen. And so we got to be careful. I always say administer and stand back because they may come out slugging. They don't know who you are, but someone on the street versus a family member. So we have to be careful, and when we give this, that we're recognizing that there is a risk that this person could be very aggressive as they undergo acute withdrawal. You basically taken that opioid off the receptor abruptly, reversing its effects so they can start breathing again, but guess what? That also means they're going to have a bunch of other issues going on in their body, from from GI effects to central nervous system effects. All sorts of things may be happening. Again, it's not a substitute for the emergency medical assistance. If there's a prolonged time, we have to give that second dose. And recognizing this is an interesting one. We're using a lot more buprenorphines. We're using a lot more of these some of these partial agonists and antagonist drugs. Sometimes not so much the tall ones. So we have to recognize that we may need a larger dose, and so keeping that in mind. And the aggressive behavior, again, I put that warning up there. Let me see what time we're at for a break time or not. Let's go a few more minutes and we'll take a break. Does that sound good? All right, perfect. Pardon? Okay, till 9:30. Okay, it's 9:16. People are hungry. Let's take a break now so you can get some more food, because once they take it away, then you're going to be going, I went too long. So let's come back at 9:30, and so about 15 minutes and we'll continue. Thanks, Charlene.